Thank you, Lisa, for the committee's information. I will be chairing this this part of the meeting until such time as the committee nominates its chair and vice chair, which is item number 3. So it being 9 a.m., welcome everyone, and a happy and great 2022 to all of you. We'll start with the disclosures of pecuniary interests. Are there any members who wish to declare any conflicts of interest at this point in time? If not, declare throughout the meeting should they arise. Now we get into the nominations aspect of or portion of the agenda. The committee is now being asked to nominate a chair. Do we have a nomination? Councillor Broad, please.
I nominate Brad Loosely to be chair.
Is there a seconder on that nomination? I have Deputy Warden Hand. So it is Councillor Broad nominates that Brad Loosely. Councillor Loosely. Oh, I've got Councillor Loosely who wishes to speak. Yes.
Now, I appreciate the confidence of nominating me, but at this time is not the time. I'm going to withdraw from that at this time, but would certainly consider it maybe in the future.
Thank you, Councillor Loosely. Given that, any other nominations that the committee wishes to entertain? Councillor Stark, please.
I nominate Steve Arnold.
Councillor Stark nominates Councillor Arnold as chair of this committee. Is there a seconder on that nomination? Councillor Loosely seconds. Councillor Loosely seconds the nomination. So we have a nomination from Councillor Stark, seconded by Councillor Loosely, to nominate Councillor Arnold as the chair of this committee. I will proceed with a vote on that. All in favor? It looks like we have a majority. Congratulations, Councillor Arnold. I will pass over the meeting to you to proceed with the nomination of a vice chair.
Well, I'd just like to thank my nominator and everyone for their support or confidence in me as chair. I'll do my best. How's that sound? And the first order of business that I have is to have a vice chair nominated. So I'll open the floors for nominations. Councillor Bradley, go ahead, sir. You're on mute, sir.
I'll nominate Councillor Stark if he's interested.
Okay. And I don't believe we need a seconder, do we, Mr. Clerk?
Oh, that's fine, as long as you get the vote.
Okay, thanks. Councillor Stark, are you willing to stand as the vice chair?
Yes, I am.
Is there any other nominations for vice chair? I'll call it once more. Any other nominations for vice chair? Seeing none, I'll declare these nominations closed, and just a confirmation vote for the vice chair, Councillor Stark. That be carried. Thank you very much. We also have the Agricultural Advisory Committee, and it's a one-year term. So is there any nominations for the Agricultural Advisory Committee? Councillor Bradley, go ahead, sir.
Councillor Arnold, are you interested, or Warden Marriott? Or Councillor Weaver?
Or Councillor Broad?
Yeah. Was he? I didn't see him on the call.
Yeah, he's there.
Well, why does whoever wants to be on, put their hand up, and I'll move the motion. I'm sorry, I can't see everywhere.
Oh, that's okay, Mike. Is there anyone on the committee that would like, Councillor Weaver, go ahead, sir.
I was going to say Councillor Broad would be good for our Ag Committee, so if he's willing.
As long as he's got time and he's willing, that's good with me too. Are you okay with that, Al? Sure. Okay, thank you. Any other nominations? In the minutes, it should be that Councillor Bradley has made the motion, and Councillor Weaver will put you on as a seconder, if that's all right. And Mike's named everybody and such. So if everybody's okay with that, please signify with the raising of their hands. That's carried. There's also a note here in regards to the Emergency Services Committee, and also we need 4 members to go to the Audit Committee in addition to the Warden. Anybody got any great ideas on how to do that, or who wants to volunteer? I'm okay with being on the Audit Committee. Mike, go ahead. Mike,
Yeah, I was gonna say,
I'm prepared to sit on the Audit Committee as well.
Yeah. So we need 2 more. Brad, thanks. Bev, thanks. So if that's all right with everyone, a show of someone to move that, or to nominate those 4. Nilani, thank you. And also just a confirmation vote that everybody's okay with it. Show of hands. That's carried. Thank you very much. And the Emergency Service Committee, we talked about that. The Woodlands Hearing Board, I guess the chair is automatically on that, so that's fine. And is there anything else, Mr. Clerk, that we need to deal with at this section of our meeting?
Thank you, Chair Arnold. No, at this point in time, you may proceed to the Board of Health unless there are questions or point of orders from any other member.
Okay. Anyone have any questions on what we just did and forthcoming stuff? Seeing none, let's move forward then. So I'll call on Dr. Renaday to give his update on COVID-19. Dr. Renaday, I see you're on the call and you're on mute, sir. So whenever you want to live your mic, the floor is yours.
Great. Thank you, Councillor. Can you all hear me?
Yes, sir.
Okay, great. And I will just ask the administrator of the meeting to give me permission to share my screen with you all. Once I have that, I will I'll share my screen as I've done in the past sometimes. There's a lot to talk about today, and so I wanted to make sure that there was some structure to that and try to give you a sense overall of kind of what's happening and where we're going. Those are the 2 key pieces. So I'm going to see if I can share my screen with you now. And then if it works, I'll just confirm that you can see the screen and the presentation. Can you see that? Okay, perfect. Great. Okay. So, today there's a lot to talk about, as I said. I want to touch a little bit on the local and provincial situation and what the impacts that has, as a follow-on on all of these different parts of the response. So case and contact management, the health system, what's going on with testing, what's happening with vaccines, what's happening with treatments, and then a little bit of a look ahead in terms of what we can expect in the next few months. So this is a graph that I have pulled from the Lambton Public Health website, and it really shows the course of the pandemic since the very beginning, April 2020 to now. And so the dark blue line, if you can see it, is Lambton County's 7-day incidence rate. The light blue line is the province of Ontario's 7-day incidence rate. And you can see in general right now, we're tracking very closely with the province. But the key point here, and I think you all know this, but it's just, I hope the visual representation really sort of pushes this point, that the amount of transmission of COVID that we're seeing here is many times higher than the amount that we've seen in our largest wave ever, which was in January 2021, right? And so the numbers of cases, the daily case counts, all of those things that we're seeing are much, much, much higher than any wave that we have previously experienced. It is a different day. Although the numbers are high here, you have to remember that the context is very different. The context in January 2022 compared to 2021 is a highly vaccinated population, a different variant of disease that is highly transmissible, but on average is less severe. And the one other thing you have to note here is that because of changes in the PCR testing eligibility, these numbers here may not be very reliable, right? So this upward trend is very reliable, but what's going on here is not very reliable, and I'll talk about that in a second. So just again, when you look at this is just isolating the provincial situation. Here's 2021, here's 2022, and you can see that these cases here are many, many, many times higher than the highest peak that the province experienced, which was over here in, looks like April 2021, right? Okay, so here are the key points here, right? The transmission of COVID is many times higher than any previous wave, and this is largely driven by the Omicron variant, which we expect to be the majority of cases across the province and probably across Canada at this time. right? The short term, if I just go, I think I can go back here, and you're seeing this sort of steep drop, right? And you think, well, does that mean cases are going away? That reduction in the short term is more likely due to changes in testing eligibility than to changes in transmission, right? This is a very transmissible variant. And we estimate that for every case that we know about, there are probably 4 to 6 cases in the community that we don't know about. So those two things put together mean that the current case counts that we report on significantly underestimate the true incidence of disease, because fewer people are eligible to be tested, and also there are more likely to be undetected cases out there based on how transmissible the virus is. So that has overwhelmed a number of systems, right? That has overwhelmed the case and contact management system across the province, which has required us to start focusing on the highest risk settings. So acute care, long-term care, and some other congregate settings are really the focus of case and contact management. The purpose of case and contact management has also changed, right? When you have small amounts of disease around, case and contact management can be used to control disease transmission. But with vast amounts of disease incidence, case and contact management doesn't really, it's not able to fulfill that function. And so the purpose of this shifts to mitigating the impact of transmission in highest risk settings rather than to try to drive down transmission in the community. And also you're seeing changes to the isolation guidance, right? So the parameters around who should be isolated and when and how, and what I would suggest is that a lot of that guidance is really in flux because of the transition from trying to contain the disease to trying to mitigate the impacts of transmission. And while the guidance is in flux, I would suggest that there are many more moments where the guidance is less practical to implement than we would like. And so certainly anyone with symptoms, we advise them to self-isolate, and the current guidance sort of goes beyond that, and anybody in a household with symptoms should isolate. But I think that when we look at that practically with the level of disease in the community, and also when we think about how diseases move through families, it's not like everyone gets it at a time. One person gets it, then another one does, then another one does, then another one does, which would mean that whole families would be sort of isolating for 20, 30 days, which is probably not reasonable or practical, right? And we don't even know about most of those cases. So there's a lot of flux in terms of what the guidance is suggesting as that sort of comes more in line with the idea that interventions to control transmission are no longer the purpose. They will become more practical, but right now they're in this middle space of they're not quite aimed at transmission reduction and not quite fully on the mitigation side either. There have been some health system impacts, and that's important for us to recognize and remember, right? Ontario and Quebec have recorded their highest ever rates of hospitalizations. And we're seeing a continued increase in that, but it's increasing at slower rates. The important thing about the difference between Omicron and previous variants is that the pressure on the hospital system is not really exclusively in the ICUs. There are a lot of people who just need a short stay admission, 2 to 3 days, rather than needing ICU care. And so there are pressures not just on the ICUs, but also on regular ward beds for people needing, that's a typo there. It should say 2 to 3 day admissions related to COVID, right? The other impacts on the health system are, the primary care system has been in a great state of flux. Some people are providing virtual care, some people are providing in-person care, but it's very important that people with symptoms are able to be seen and treated outside of the hospital system. And so, there's an initiative in the health system right now to make sure that the testing centers, or the things that were testing centers, are now moving towards more assessment of respiratory disease. And then they're able to triage that and then take people who are more severe or who need more severe follow-up and do that compared to people who can be managed effectively at home. And then we should expect that there will be ongoing surges, right? We should expect that there will be peaks and valleys in COVID admissions over the next several months, and also that the healthcare system, especially the acute care system, will need to have this sort of delicate balancing act to balance the backlog of surgeries and procedures that have been delayed, the new surgeries and procedures that need to happen, as well as any admissions related to COVID. And that's going to be an ongoing issue for the acute care sector. Very briefly, right? there was no way that all of the people who had symptoms could be tested with PCR for this virus, right? The lab capacity is not sufficient, and you've seen, already significant backlogs in that with the given amount of testing. And so the testing parameters have been changed. The PCR testing is now reduced in eligibility to those at highest risk for severe disease, those in the highest risk settings. The implications of that on the public health side are that we do have a less comprehensive picture of disease, right? And so two things about that. One, if you're only testing the people at highest risk of severe disease, it's going to look like the disease is more severe. So that's really important, right? Because you're not testing all of the people who are just having mild disease and staying at home. You don't get a sense of the true burden of disease. But I think we know enough about this disease to say, to go back to the things that we did know when we had good surveillance on it, which is to say, largely people recover at home with this. Largely, they do not need additional care, but your risk is greater if you are older, and that risk is exponentially higher as you go through the age ranges, right? So we don't have as much of a comprehensive picture on it. We also don't have as much of a comprehensive picture on the baseline incidence of disease, right? Because you need to do far more testing than just hospital-based testing or acute care-based testing to figure out how much disease you have. And so that aligns with the change in goals, right? Moving away from managing COVID transmission and prevalence to mitigating the impact of that. But it's a challenge for a lot of people. And I think that's going to be a hard one for people to kind of move through. Why do we not know how many cases there are and so forth? And so certainly right now, there are so many cases and the numbers are so unreliable that really we should be saying there's lots of disease. It's out there just like other respiratory viruses, and use the tools that you have to reduce or delay transmission to you. But the purpose has shifted, and I think there are a lot of people who look at those numbers in different ways, and that's going to be harder over time to be able to do. Okay, I'll shift over to a slightly better news story in terms of COVID vaccines, right? So I think Middlesex London, our neighbor, is reporting a 1 million dose milestone, and we're verging this week on a 250,000 dose milestone, which I think makes sense based on our relative population sizes. So this week we'll probably be hitting 250,000 doses of COVID vaccine administered. We have 77% of our eligible population that has had 2 doses of the vaccine, and that's excellent. That's a good number. Especially because it's largely in the population that is at greatest risk of severe disease, right? Our the vaccination coverage rates mirror the risk of severe disease in the population. So the people at highest risk also have the highest rates of coverage, which is good. We've increased our delivery capacity for vaccines throughout January in our public health clinics as well as in pharmacies and healthcare. So last week we did over 11,000 doses, but in general the average is around, we're able to do about 10,000 doses a week as a system, and in large part through the expansion of public health clinics as well as additional capacity in pharmacies and some healthcare clinics as well. And remember, when we're talking about the vaccine, right now is the time that we actually need to pause and have really significant discussions on what is the vaccine for, what is the effect or impact that it's having on the population, and therefore what are our next steps with the vaccine strategy, right? It's important to remember that 2 doses or 3 doses gives you good protection against hospitalization and severe disease, which are the outcomes that we care about the most. But where there was an opportunity to be using these vaccines also to reduce transmission, and it was looking in the early stages like you had good protection against any symptomatic disease, it does appear that that protection wanes after about 10 to 12 weeks. So when you get a dose, you have about 10 to 12 weeks of protection against symptomatic disease, which wanes over time, but you maintain protection against hospitalization or severe disease, which is good. It does signal a shift in the strategy of the approach to vaccination and who should be vaccinated and over what period of time, right? Health Canada recently, I believe just yesterday, approved an oral outpatient treatment for mild to moderate COVID disease. It's called Paxlovid. It is an antiviral treatment, and it's taken for 5 days in a row. I do not have information on how this will be rolled out. The routine mechanism of rolling out a drug would be that it is, purchased, made available at pharmacies, and then if you are, it'll either be put on the eligibility list for all Ontarians, or the way that normal drugs are distributed. So that's one possibility, right? The other possibility is that there will be some alternate or parallel mechanisms for distributing this drug, just given the context. And I don't have any information about how that's going to roll out. But as I hear about it, or as we learn more about it, then I'll be happy to share that with you at future updates. There's also no current information on who will be eligible to take this antiviral combination treatment. Remember, it is not indicated for people in the hospital with severe disease. It is indicated for people outside of the hospital. It is also, when I look at the product monograph, not a simple medication. That is, there are a lot of interactions with other medications. So it will require a clinical assessment in order to prescribe Paxlovid, most likely, compared to just being able to get it over the counter because you have a headache or because you have a symptom that you think might be COVID, right? It's also possible that there won't be enough of it. And so there will be some eligibility around that related to who is at highest risk for severe disease, right? Again, there's a lot of uncertainty. I think it's good news that it's been approved by the regulator, and now it's all of the next phases about how should it be used and how should it be distributed. So looking ahead, right, we've been doing this for 2 years. That's a long time in the grand scheme of things, but an average amount of time in global pandemic speak. Most pandemics take about 2 years to sort of have their full impact and resolve, and we're coming up on that mark soon, but not quite yet. So it's important to remember, right, that restrictions, long-term restrictions, they may reduce the transmission over time. They do take a long time to work. We've seen that before, and they take longer and longer with each successive round for reasons that we can get into later. But with such a transmissible variant, we have to accept that many or most people will be exposed to COVID over the next several months. There are, some exceptions to that are people who can fully and completely socially isolate themselves. And if they choose to do that and they believe that if they're able to do that, and if they're, but even then, most people will have some social interactions, and those social interactions will bring them into contact with COVID, just like they can bring them into contact with the flu or cold, right? WHO Europe is estimating that about half of the European population will be exposed in the next 4 to 6 weeks, and that's really significant. I think that those kinds of indicators, alongside with modeling that suggests, that this is going to have a baseline prevalence that just kind of sticks around and goes up and down, means over time, people will be exposed to this. It will merge into the set of respiratory viruses that circulate that we have to manage in any given year, like we manage flu. This is a point of awareness, but not a point of action for us locally. But, global variant surveillance is very critical to ensuring an ongoing response to this pandemic, because Omicron is the one that we know about and we're dealing with, but frankly, it's highly likely that there are already other variants out there that we don't know about, and the assessment of the severity of those variants is going to dictate the future response, right? So we do need that capacity to assess global variants, especially given that most of the world has not had access to vaccines yet. And we have to start moving people along towards living with risk rather than avoiding the risk, right? We're going to move to symptomatic diagnoses, the presumption of COVID if you have COVID-like symptoms, and a greater understanding that normal interactions over the next few months will continue to result in COVID transmission. And we have to start moving towards a system of treating it like the normal circulating set of viruses. We have vaccinations, and that's good. We have increasing treatment options, and that's good. We have, on average, a less severe virus, and that's good. But the hardest piece about this is getting people to start accepting the risk of COVID as part of other risks that they routinely take. That is going to be a huge cultural shift after 2 years of really trying everyone's level best to prevent exposure at all. And we'll do our best to sort of guide everyone through that, but that's the big mindset shift that needs to happen in order to really adjust to the ongoing prevalence of COVID that we expect to have around. That was a lot, but there's a lot going on. So I'm going to stop my screen. Hopefully you can see me now.
Yep, I can see everybody now. So thank you very much, Dr. Renaday. Appreciate your update. Is there any questions for the doctor? Councillor Stark, go ahead, sir. You're on mute, Mike. There you go.
Thank you, Mr. Chair. Doctor, thanks for the update. I have several questions, but I'm going to limit it to one, and that is recently the national news has concentrated on Sarnia/Lambton County. And as the introduction to their several pieces, they talked about the fact that Lambton County is running 5% below the provincial average in terms of number of vaccinations. One, is that correct? And two, is there any way that we can bring to the public's attention, other than what we're currently doing, the need to get vaccinated and boosted? It seems that if we're running 5% below the provincial average, we seem to have a problem. Could you comment, please?
Dr. Renedy?
Sure. Thanks, Councillor. I think it's always tempting, and it's been tempting through this whole pandemic, to look at our numbers in comparison to others or to Ontario and say, this is bad, this is good. I think it's actually more nuanced than that. It's neither bad nor good. I think historically we have had a lower rate of immunization coverage in general compared to Ontario with all immunizations, right? We also have a population that has higher, rates of chronic disease risk factors. We have higher smoking rates than the average Ontario population and so forth, right? So there have always been times and topics where this community and others have stood out from the average, right? And then the question is, what is the impact of that? So when we have 77% coverage of our population compared to, 83% coverage at the Ontario average, first of all, remember, averages are such that there's always outliers on either side, right? So there's always going to be someone there. And then the question is, what's the difference at the population level of having 5% less vaccination coverage? So first I go to what's the distribution of that coverage. And it's very well distributed in terms of it is the people at highest risk of severe disease who have the highest rates of vaccination. And that's good. That is what we want, right? Where we are seeing lower rates are in the population that A, thankfully is at lower risk of severe disease, but B, has always been less likely to be immunized. So when we talk about our global immunization program in Lambton County, we have really good coverage rates for the pediatric vaccines, the 0 to 5-year-old vaccines. We have excellent coverage rates, but then our coverage rates drop off in the adolescent and adult vaccine area, right? So that's partly a cultural phenomenon. We've done most of what we can to do with related to access and improving access. So it's, the thinking is that access is not really the problem anymore. It's just people's sort of general hesitancy towards vaccination. And that takes time, actually. That's not something that you can overcome in a month or 2 months or 3 months. That takes time. It takes relationships with trusted healthcare providers. And so we work on that, but we work on it at a slightly different level, because communications work will not sort of shift the last 5 or 10% of folks who have waited this long and are still not interested in being vaccinated, right? So it's not a communications issue. It's not an access issue. It's really partly a belief system issue, and that they need some other people in their network to help have those conversations with them. So I think that's probably we're at as good as we're going to get in terms of what large scale interventions can do to improve coverage. The only other one where we do see a bump in coverage, at least transiently, is policy solutions. So when there are policy solutions requiring, vaccine, proof of vaccine in order to do different things, that does result in increase in vaccine coverage. And so that's a policy tool that's been used, and it did result in transient increases in coverage, but there are people who are just not going to get vaccinated, and we have to accept that.
Thank you, Doctor. Any other questions? Councillor Napper, go ahead, sir.
Thank you very much, Mr. Chairman. I guess maybe you covered this. We have the COVID testing center here. What do you see as the future in that, and who makes a call on that, whether it closes or stays open? Or there seems to be some confusion on that. Give me a little clarification.
Dr. Renedy?
Thank you. I will try, Councillor. It's the testing and assessment centers are really being driven by the healthcare system side of things. So the Ontario Health and its relationship with the different healthcare providers, right? The testing eligibility is determined by the province, and we've seen that shift over time. And moving the testing centers to clinical assessment centers is an Ontario Health kind of initiative. And so though I believe that they're making the decisions about where should these be and how should they operate. But if I could just project a little bit farther out beyond the next 2 months or 3 months or whatever, in an ideal state, right, you would completely, sorry, there's a word that I'm searching for and I can't remember what the word is, but you would, decentralize. In an ideal state, you would decentralize that work completely. And so rather than having specific assessment or testing centers where people go, you would go to your primary care provider who has the ability to test you for COVID, like many of them have the ability to test you for flu with a rapid test, right? And so in an ideal state over time, you would just go to your primary care provider with symptoms. Those symptoms may or may not be COVID. And then it's up to the person assessing you to decide what could be going on, to do the right tests and to give you the treatment that you need, right? So I'm hopeful over time that we'll move to that model, because certainly taking these resources and saying this is just for COVID testing, this is just for COVID assessment, makes some things in the system that are harder to make work than if you were to distribute it the way the system normally works.
Okay, thank you, Doctor. Any other questions? Deputy Warden, go ahead.
Sorry, I just wanted to comment to Mike Stark, Councillor Stark. What was said to me from the hospital was the focus of that CBC interview was because of the letter that was written, the open letter to the community. It wasn't because they targeted Sarnia because of the vaccination rate. It was because of that letter. So that fact came out in the interview because they focused on the hospital. They spent a whole day at the hospital interviewing and filming, and then made the 2.5-minute segment. But it was more directed because of Dr. Haddaday's letter to the public that caught their attention. So I just wanted to point out that difference. They were focusing on us because of a low vaccination rate. It was more about what was happening here locally at the hospital.
Okay. Thank you, Deputy Warden. Councillor Broad, go ahead, sir.
Thanks, Chair. Question for Dr. Renaday. You just mentioned about you see the future being going to your primary care provider to get the tests and stuff done. I don't know about anybody else, but trying to get into my primary care provider, my doctor, I'm looking at 1, 2, 3, 4 weeks, maybe 2 months, whatever. I think, timing's going to be of the issue. How, unless they're going to revamp everything they're doing in the doctor system or family health units or teams or whatever, how are we ever going to achieve that?
Dr. Renaday?
Thank you, Councillor. So when I say long-term, I do mean longer term. So in the short term, yes, we do need to have the ability for people, because we're aware of the fact that there are a lot of people who are not able to see their primary care provider in a timely way, the way the system is supposed to work, right? And so because of that, if you have symptoms, the system is trying to figure out how can you get seen quickly and assessed, regardless of who your primary care provider is, right? But your larger question is incredibly accurate, that there are primary care systems issues across the province that need to be sort of addressed in terms of ensuring access to care, in terms of ensuring, care provided between care providers is, working the way it's supposed to. So the Ontario Health Team is an initiative that the Ministry of Health started to try to address some of that. And I would just say there's a lot of really good partners at the table to do that. Historically, primary health care transformation goes through many, many waves. And so far, you know, like everybody's hopeful that the Ontario Health Team will do something dramatically different. But I think, you know, we also have to look at the history of primary health care operations and how they're not very highly structured and highly organized, right? So I completely agree with you. There needs to be a better primary care system. There is work ongoing to do that, but it's a slow moving process and a large unwieldy system to move.
Thank you.
Thank you, Doctor. Any other questions? Seeing none, Dr. Renaday, thank you so much for your update and addressing all the questions here. And it always seems like when there's a question, there's always 5 more that are stimulated in our minds. So anyone that has any questions, they can follow up with Dr. Renaday at any time. And so thank you once again, sir. Much appreciated.
Thank you. So
the next thing we have, Council, is in regards to Infrastructure and Development Services Division. And there's 3 items, A, B, and C. And what I'll do is I'll ask for a motion to receive those as information, and then we'll do the individual motions after for each one. Moved by Councillor Stark, second by Councillor Napper. All in favor to receive that as information? That be carried. Item number A, there is it's a report regarding County Road 7 Lakeshore Road parking restrictions, and there is a recommendation there. Does anyone want to move that recommendation? Councillor Bradley, seconded by Councillor Stark. Any questions? Seeing none, all in favor? That be carried. And I think that there was only the one, wasn't there, Jason, under number A, one recommendation?
That's correct.
Thank you, sir. Item number B is the road widening dedications on County Road 26. Could I have a mover and seconder for the recommendation in regards to that? Councillor Broad and Councillor Stark, any questions? Councillor Stark, go ahead, sir.
With respect to, and this is a question that for Mr. Cole, it would apply to both B and C. As I read through the reports, it indicated that the financial implications were basically legal. The question is a generic question in the sense that with road widenings, are there any land acquisition costs involved, and who bears those costs?
Mr. Cole?
For you, Mr. Chair. Councillor Stark, it all depends on how we acquired that property and the reasons behind it. So if we were going out and seeking that property from a landowner for a widening or an improvement on the roadway, then there would be land acquisition costs and other, like normal real estate transaction costs at that time, and that would occur as part of that project. So then these reports are formalizing those pieces, those parcels of land as part of the roadway. And that's just a standard practice that we've tried to do to make sure that they're registered, that the landowners keep us and the previous landowners keep track of them. And that happens, we get into complications all the time when people are trying to sell their properties and they've previously parceled off pieces of land. So that we make sure we register them at the office, and then if there's no confusion as to whose property that is.
So this exercise is really a clerical sort of a issue as opposed to any acquisition issues. The acquisitions have already occurred.
Yes, sir. Yeah. Yes, sir. Yeah, and in the first report, it was done a long time ago, and we found these properties that the housekeeping wasn't done on, and that was standard practice at the time. So we just try to update those as we realize them. For the other ones, for the second report, a lot of those properties were acquired on roadways where we know we need to widen the roadways, and there was a severance or other improvement on the property that occurred, and then those pieces of properties were granted to us.
Thank you very much.
Okay, thank you. Good question. Any other questions in regards to B? All in favor of that recommendation? That's carried. And number C, very similar, only a lot more widespread. So could I have a mover and seconder for that recommendation? Councillor Weber, seconded by Councillor Broad. Any questions or comments? All in favor? That be carried. Is there any other business, Jason, that you and your folks would like to bring up at this time?
Oh, I believe that concludes our reports. Thank you.
Okay, thank you. Any member of committee? Councillor Weaver, go ahead, sir.
Yeah, I'm just wondering about the county entrance sign on 402. Is that proceeding?
Mr. Cole?
Where we left that.
Yeah. Yes, through you, Mr. Chair, and that's a very good question, Mr. Weaver. I have a request to talk to a media outlet this afternoon regarding that. Yes, so late last year, we had a report indicating that that sign had finalized design and we were going out for tender. We outlined the costs of what we thought was going to happen with that sign and indicated that we have room in our surplus for 2021 to cover the additional costs. So over the break, we were able to tender and we awarded that contract to KWS Electrical Services out of London. They're affiliated with Briex Construction and had several other subcontractors listed with them. We had our site meeting last week, last Wednesday with KWS, and they intend to start construction on the sign with fabrication and other prep work shortly in February, and it has a completion of June of 2022 scheduled, and they believe they can meet that timeline.
Very good. Thank you, Mr. Cole. Any other questions? Seeing none, thank you very much, Jason. Much appreciated. And the next piece we have, Council, is the Public Health Services Division. There's two items of correspondence. And I'll ask for a motion to receive those. And if there's anything anybody wants to do, we'll go from there. Councillor Weber and Deputy Warden, all in favor of receiving those two pieces of correspondence? That's carried. Does anyone may want to make a motion on either one of those items of correspondence? Seeing none, we'll move on then. Information reports. There's an information report regarding the COVID-19 activities update. Could I have a mover and seconder to receive that report? Moved by Councillor Weber, seconded by Councillor Broad. Any questions or comments in regards to that information report? Seeing none, all in favor of receiving that? That be carried. I see Mr. Taylor's on the line with us. Andrew, did you have anything good for us in regards to any of those reports or information at this time?
No, Councillor Stark. I do want to draw your attention to the second report, the information report in the package today with respect to the work that's been ongoing between staff and in the senior leadership of EMS and Sarnia Fire Service. So I'm pleased to report that those discussions are proceeding very well. And the good news is that this business is normalized. It's moved back to the staff level. And we don't anticipate any issues going forward. So this report has been provided in there as well for your information, and I'm happy to take any questions if there are for that report as well. Okay,
I'm just coming to that one, Andrew. Thank you. So we have our next one is the Emergency Medical Services Department Information Report. Could I move and seconder to receive that as information? Councillor Bradley, Councillor Broad. Any questions in regards to that one?
Yeah, just a comment. After a year of this discussion, I'm really pleased to see that the momentum's there to resolve the issue, because it was not productive. And I think everyone knew that wasn't productive, but it had to be dealt with. So I compliment all those who engaged in this, and it's been lengthy and detailed, and it looks like a very positive outcome at the end.
Okay, thank you. Councillor Loosley, go ahead, sir.
Yeah, thank you, Chairman Arnold. Just a couple of things. I'm pleased too to see that we've come to a bit of a solution, but I just wanted to make a couple of comments. Just my concern is the idea of they said chest pain calls without lights and sirens and to be upgraded or canceled as appropriate, and that means no lights or sirens. I would hope that somebody's going to keep a record as of how many times they actually continue on, or they just start out and go back. To me, that seems like a bit of a waste of time and money, although that's just one of my concerns. And the other was a narcotic overdose with decreased level of consciousness. I really question why the fire department would get involved with that. But I just wanted to mention it. I am pleased they come up with an agreement, but and I'm going back to when Dr. Davis approached us and brought some of this information before us. And again, I hate to see all these people going out when there's really no need. But again, that's just my concerns that I wanted to bring to your attention. And if I can leave it at that, Mr. Chair, I have one more item I'd like to ask. I'd like to ask Mr. Taylor, I thought there was some discussion at the last meeting that there would be an EMS update on the master plan coming to the committee in January. And I just wondered where we're at with that, Mr. Chair.
Can we hold that just for a second, Councillor? Because I'll call the question on this report, and then you can bring that up other business, if that's all right.
Absolutely, no problem.
Thank you very much. Deputy Warden, did you have a question?
Yes, related to the overdose situation.
Okay, is that part of what we're doing here right now, Bev, or is that other business?
It's what Councillor Loosely just mentioned that he had a concern about.
Okay, can we do that on other business? Because I haven't called the question on receiving this report yet.
Okay, sorry. Yep.
That's all right.
Mr. Chair, this is part of what we're discussing now. This is in the report.
Okay, it's responses, but you were talking about a report that's forthcoming in January meeting. So that's why I said to bring it up under business, unless it's
and that's no problem. Report. But I'm talking about what Bev just brought up. That's part of what's on the report you're discussing now.
Isn't that part of the response time? And who responds when? Is that what you're talking about, or are you talking about a further report I thought that was going to come here in January? Maybe I misunderstood.
It's what's listed in the tiered response.
Okay, go ahead then. Who wants to go first? Brad, do you want to go first on that one?
No, I'm going to deal with mine under other business. I was only bringing to your attention what Bev brought up is what we're discussing now.
Okay, because she referenced you, so that's why I thought it was separate. Bev, go ahead, Deputy Warden.
So Councillor Loosely made a comment that he was concerned about the overdose on the list.
Okay.
And I believe that, I know in our community, the fire department has the Narcon kits. And if the fire department can be there quicker than EMS, they have the kits on board. And I think that's why that appears on the list. I'm just suggesting.
Okay, thank you. Councillor Lucy, did you want to respond to that?
Yeah, thank you, Mr. Chair. No, that's good. It's good to know. Thank you for that, Bev. It's good.
I think most of us have Narcon kits on, and will respond as required or requested. So, all right. Any other questions in regards to the tiered response agreement that's being discussed? Seeing none, all in favor of receiving that information report? That's carried. Other business, Councillor Loosely.
Yeah, thank you, Mr. Chair. And maybe I misunderstood, but I thought Mr. Taylor had mentioned at the last meeting, or one of the meetings in December, I believe, that this the master plan for the EMS update would be coming to the committee level in January. And I'm just wondering where we're at with that, Mr. Chair.
Thank you. Mr. Taylor, could you respond to that, please?
Yeah, thank you. Through you, Mr. Chair. Yes, Councillor Loosely, last time we had endeavored to follow up with an update with respect to the systems performance review that the consultant was doing. I'm pleased to report that the consultant has provided a report. We received it on Friday, January the 14th. So staff are currently analyzing the information in it, and we'll be reporting to County Council with an update with a view to have the consultant attend a future council meeting to present the findings. Because there's a lot to absorb in that report, but I can tell you overall that the report indicates that we've dispelled a few of the concerns around Sarnia being a magnet and pulling service into the city of Sarnia. And but however, it does identify some system pressures that we're going to come back with some recommendations for. So we have received the consultant's report, and we'll be further reporting on those findings and bringing the consultant in to do a presentation to County Council, likely in April.
Okay. Follow up, Councillor Loosley. Go ahead, sir.
Thank you, Mr. Chair. No, thank you through you, Mr. Taylor, for that information. That's good.
Very good. Thank you very much. Any other business to be brought forward at this time? Seeing none, thank you, Andrew. Much appreciated as always. The next one we have, Council, is information reports from the Cultural Services Division. And we have two of them, A and B. And could we get a motion to receive those as information? Moved by Councillor Stark, second by Councillor Weber. Any questions in regards to either one of those reports for Andrew? Councillor Bradley, go ahead, sir.
I'm really pleased to see the, I do have a bit of a conflict of interest regarding removing fines from overdue library materials.
We aren't quite there yet, Mike.
Okay, just want to highlight that.
I think you're the exception. They're not going to let you off, is what I understand.
I'm sorry about it. I jumped the gun. I was so eager to put this in place.
Very good. Anyone have any comments or questions, Deputy Warden, in regards to the two information reports?
I just wanted to commend them on the reports. They're well done, and it's makes us feel good to see what they've been able to continue to do and be innovative through this last couple of years, so that, you know, we still have our library services and cultural services as best they can. So thank you for that.
Very good. Thank you, Deputy Warden. Go ahead, Councillor Bradley.
Yeah, I just want to add that through the pandemic, libraries have proven, you know, people years ago used to say, well, they're going to just disappear because of social media, internet, and everything else. Libraries have proven their value through the pandemic. And there's a great quote I love that I think it's Toffler that said, libraries are hospitals for the mind. Mm-hmm. And in the last 2 years, I think the library system, the cultural group have proven that. And it's made a difference with people. I particularly note it within the community with the services provided here. So there's a big thank you for that. It's helped a lot.
Absolutely. Good comment. Excellent. Okay. Any other comments or questions? All in favor of receiving those two information reports? That be carried. The next report we have, it requires a motion with the exception of Councillor Bradley. He's exempted from the overdue charges. Oh, sorry, I didn't mean to say that. So what I'm looking for, Council, is a motion to receive the report by Councillor Stark, Councillor Broad. All in favor? That be carried. And there is a motion there or a recommendation. Councillor Stark, go ahead, sir.
I'd like to move the recommendation and echo Councillor Bradley's comments. This is one of those situations where we throw out the concept of money is everything. And the reality is that the libraries have provided an invaluable service. And if we can somehow support that by eliminating fines, all the better. So thank you very much for the recommendation, and I'm pleased to move it.
Thank you very much. Councillor Bradley, you're just going to second that? And you'd like to comment on it? Go ahead, sir.
Yeah, I've raised this many times over the years. It may sound, Councillor Stark's alluding to it, may sound fiscally irresponsible. It's not. The fine system, particularly young people, socially disadvantaged people, actually was a denial of services to them. And I understand why it was in place. It's been in place for 100 years, but we're just joining a large number now of libraries saying, look, no, this is counterproductive to what we want to do, which is to inform, educate people and give them to love books. So I'm really pleased to see we've arrived at this place, Mr. Meyer, and I thank you for that.
Okay, any other comments? Councillor Weber, go ahead, sir.
Clarification. So we're removing the fines, but if you don't return the book for 30 days, you have to pay for the book. That goes on so you're not getting fined for being late, but if you don't return it at all, you're responsible for it. Is that correct?
Mr. Meyer?
Through you, Mr. Chair. Thank you for the question, Councilor Weaver. And yes, you're correct. So fees will still be in place for unreturned materials or damaged materials, just on a cost recovery basis. So this is just pertaining to the elimination of late fines, which, as has been noted, is really a barrier to access of our libraries.
Very good. All right. Any other questions or comments? All in favor of the recommendation? That be carried. Thank you very much. Is there any other business, Mr. Meyer, that you'd like to bring to the committee from the Cultural Services Division at this time?
Perhaps just a comment, if I may, Mr. Chair. Just appreciate the support of council, and I'll certainly extend those kind comments back to our staff team. So much appreciated. Excellent. Thank you very much, Andrew. Any other business from the committee in regards to the cultural services? Seeing none, thank you very much, Andrew. Appreciate the reports and also that recommendation. That was excellent. There's no in-camera items at this time, committee. So is there any other business that anyone would like to bring up at this point? And if not, I'm open to a motion to adjourn us. Moved by Councillor Broad, second by Councillor Napper. All those in favor? That be carried.